Well, good evening, everyone, and very big welcome to tonight's webinar, COVID at the Coalface. As always, I'd like to start by acknowledging the traditional owners on all the lands in which we meet tonight and to pay our respects to their elders past, present and emerging. Very excited this evening to be welcoming some UK colleagues to join us tonight to talk about their lived experience of managing COVID in the UK. Next slide, please, Tennille. So this is who we've got online, and you'll be able to see people. We've got Dr. Sally Eyton and Dr. Mark Hobbs, who are GPs in Cobham in Surrey. We've got Dr. Mahroof, who is a consultant in critical care and anaesthesia. Raz, by the way, we can't see you, so if you want to put your video on, that would be really good. We've got Jane Olds, who's a matron of adult critical care at Addenbrooke's, and Matt Davidson, who's a trainee in the UK at the moment. So before we get started, we'll just go to the next slide. Just to remind you all, and I know you all know how to do this, is that please to use your Q&A button at the bottom of your screen if you've got any questions. Rebecca Locke will be curating those questions and feeding them to the presenters as we go along. What we thought we'd do tonight is we would just spend the first half of the webinar going through the journey of primary care, then the inpatient experience, and then the trainee experience. So we're going to go like that, and then we'll bring the whole panel together and just go through some of the issues that are emerging at the moment for them, and some of the lessons that we can draw as we go into our next stage of managing COVID. Next slide, please. I thought this would be a good place to start. On the 23rd of March, which seems like a long time ago now, this was where COVID cases were, and you can see UK at the bottom there, 6,650 cases, and this was the day when hard lockdown was introduced in the UK. And then next slide, Tennille, if you want to show us. This was yesterday. I pulled this down last night. You can see obviously things have moved on really significantly in that time, and there you can see the UK with about 285,000 cases. So on that note, we'll go to the next slide and hand over to Sally and Mark just to start talking a bit about primary care. And Sally and Mark, when we were talking earlier, we agreed that our paths were very similar, weren't they, in primary care, up until somewhere along this point. We were both getting ready, both countries. We were all looking at Italy, what was happening in Italy. We in Australia by the 23rd of March, we were already in lockdown and had been for a couple of weeks. But I think in primary care, we were all not sleeping very well and trying to work out how we were going to manage sick versus not sick patients. So over to you.
Thanks, PA. So I'm Sally Eyton, I'm a GP. This is Mark, my husband. We both work south of London in the UK. Yeah, I mean, COVID, as you quite rightly say, PA, hit us all pretty much at the same time. And we were, I'm sure like all of you were, basically very scared at the start. We were scared on a personal basis about bringing COVID home to our families, on a professional basis of quite honestly being completely overwhelmed. We also had our staff to think about at work. We had members of staff not wanting to come in. We had members of staff self-isolating, it was a scary time to start with, and I'm sure you all had the same thing.
On to the next bullet point. We were also deluged with information, deluged with government recommendations and local recommendations, and again that was fairly overwhelming. Over time things settled down, but one useful tip: have some individual in your practices who's going to sift through it and lead on this, because otherwise you don't get anywhere.
So we, I think probably we were behind you as far as the changes to our working practices were concerned. For us, we had previously been seeing 30 to 40 patients a day face-to-face. They'd had open access to appointments. And so when we closed the doors to our practice, we then moved to telephoning, triaging all the patients and using video conferencing, and that's what we're still doing now. And we have been all the way through, and we still are seeing patients at the practice, but they are triaged and they're brought in to a separate entrance, and we're in full PPE.
Other areas, keeping staff and clinicians on side. This was a big one for us. Hopefully you've had a bit of a lead in and some time to think about this. We started off with daily staff meetings before we opened in the morning, 7:45 every morning, trying to keep staff on side. Information was coming through thick and fast. So planning on that was very helpful to keep staff coming into work. WhatsApp groups, remarkable. We all got very used to this, and there was lots of messages going around at all times. Again, on the staff and clinicians, risk assessments, this will be mentioned later, I know, but it has some unintended consequences or intended consequences. I've not seen a patient myself face-to-face for 3 months now, which adds its own stresses. I'm busier than ever doing all the other video conferencing and triage. Video conferencing, by the way, useful, but we don't use it in a lot of cases because it only has certain areas of benefit.
Yeah, and Mark, we were talking earlier, weren't we, that there's a whole set of patients who are very happy to talk on the phone, aren't they? Because they could be in the car or at the supermarket or something. They don't necessarily want you to see what they're doing while they're having the conversation with you. Absolutely right. And in our experience, good for patients, not necessarily good for clinicians, I think would be my summary. It doesn't save time overall. In fact, until people are used to it, it actually takes more time to do a video conference than seeing somebody face to face. But of course, it reduces the patient's travel time significantly.
So the next point, so just from the patient's perspective, I mean, obviously patients have had huge anxieties. They've had anxieties about them getting COVID. They've had anxieties about access to the GP, and also huge reluctance to go to hospitals, and that has been a real issue for us. And you know, I can think of examples of people who were very seriously ill and just simply refusing to go. And
that's right. And we were talking about this a bit earlier. And Jane, if I could bring you in, you were saying that in the last few weeks you've really started noticing the consequences of that. Is that correct? You're on mute, Jane.
Yes, definitely. From a neurosciences point of view, we have seen a massive increase in patients coming in with strokes and significant deficits and things and requiring critical care. It's data we're just collecting at the moment to see what that impact is. But we definitely think that is, people have been frightened to come into hospitals and haven't been accessing healthcare because of that.
And Matt, from a trainee perspective, you've been based in ED. I know you said that overall the patient numbers have been down, but have you noticed as well more recently patients turning up in the ED who perhaps have waited much longer than they might ordinarily have to be seen?
Yeah, we've seen a demographic shift in A&E of patients, and I've said it sort of before, but our second wave has actually not really been COVID, in my opinion. It's been patients who needed to present earlier with other conditions, who've neglected their either chronic or acute health conditions, and we've seen an array of conditions that we don't normally see in A&E. And it's been from patients who've not come in at a primary care level, but also even at a secondary care level. We've had patients who've been seen by the surgeons, diagnosed with suspected appendicitis, and then they've been trialed on medical management, which we all know to be pretty unsuccessful in treating appendicitis. And of course, subsequently, we'd see that patient again with a peritonitis. And so there's been a very significant demographic shift in the patient that we're seeing, you know, with the evolved strokes and even the delayed presentations of things like STEMIs. So it's been a marked shift, as you say.
I wonder, Sally and Mark, have you been seeing in primary care delayed presentations to yourselves or things that are more evolved as well from a clinical point of view?
Yes, I've certainly been doing more what we call 2-week rule referrals, so cancer referrals, than I would normally do. And those certainly are people that have been hanging on to their bowel symptoms, for instance, rather than coming in. So yes.
And I echo that on the neurological side as well. We're seeing quite a lot of people with symptoms of stroke who sat on it for a while, just not got in touch. So I think we're all seeing that. And
in a way, that's terribly sad, isn't it? Because one of the things I've been saying to trainees for years and years is, oh, in my day, we used to see these people with these awful dense hemiplegias. And now because general practice, we're so good at managing hypertension and all these risks, it's really rare. So that is really sad, isn't it? If it's a return to those very bad times of dense hemiplegias and yeah.
Just on the, on the positive side, the patients have been so appreciative of anything that we've been doing. So virtually all of our patient contacts have been extremely positive, actually. And I mean, I'm sure you're aware that there's a national clap for the NHS that went on every week on a Wednesday evening at 7 o'clock, when really it seemed like everyone came out of their front doors and banged pans together. Which was actually very emotional to start with, but actually very heartwarming. But happily that stopped now. But they were very appreciative. Yeah.
So we might defer the forward planning till later on. That's okay. Yeah.
Okay, so let's move on to the next slide, please. Quick run through on practicalities, which we hope might be of help. Consulting and appointments, we talked about a few of these. We reduced face-to-face significantly, stopped a lot of routine work. We've reflected on the implications of that and the consequences already. I think the other thing to point out, a lot of personal frustrations between clinicians, receptionists about what we can and can't do, altering the way work is able to be done, and people not being able to see patients regularly. I think we just need to be aware of all of that.
So just on to the next one, the hot sites, and it sounds like you are fully prepared for these. Sorry, back to the previous slide. I've been involved in, we have a rota, GP rota for running the hot sites, and Mark is asthmatic, so he hasn't been doing them. I guess that's the time when I've come face to face with very sick patients, because of the hot sites, they've been kept, the very sick COVID patients have been kept away from our practice to protect our staff and our patients, so that has been an absolute saving grace, the hot sites. And also we've had home visiting teams as well, who can visit the housebound or those who are unable to get to the hot sites. So if those aren't set up, they are an absolute godsend.
We've also been had to get involved in a lot of risk assessments. I think you're probably there already on that, and it has had a lot of implications and stresses among staff and between staff about who can work, who can't work, this sort of thing. So worth being prepared for that one. Working from home, this really comes on from the risk assessments. We've had to set up very rapidly.
Oh no, they're there. Sorry, we lost you briefly there. Sorry.
Sorry. Yeah, on working from home as part of the result of the risk assessments, we've had some people who have to work from home, receptionists working from home. So the IT side is just quite an important area to have running. We had to get things set up very quickly here in the UK with remote working and the IT side.
And also what has been very positive about that is that a lot of the postgraduate training, probably in Australia, it's all done like this, isn't it? But we're getting some fantastic webinars now, whereas previously we would have had to actually go to the meetings. So that's actually been a real positive, and hopefully that will stay the same.
Well said.
There's a sweet spot. There's a sweet spot between getting Zoom bottom, because you've just been on for so long, and doing what you working out what you can do effectively, I think, online, and what you need to do face to face, isn't it? We've had some big wins. We've been teaching some practical procedures via Zoom, which we never thought we would be able to do, but it can work.
Yeah. As far as the premises are concerned, and again, you've probably got this all worked out, we set aside a hot room in the practice for people who weren't obviously COVID, but the asthma exacerbations, the ones where you really don't know, and they could be COVID. And so that was one whereby it was all cleaned down after the patient had come in, full PPE, etc. We have been wearing...
Can I just question you slightly? Because there's this lovely phrase we use in Australia, it may not be used in the UK, called deep cleaning, which no one is entirely sure what that means. But when you say the patient gets, the room gets cleaned afterwards, could you just talk us through what that actually means?
So we do that. We've never used the deep cleaning because it wasn't practical to get companies in to deep clean the surgery. So after seeing a patient, so we actually just wipe down everything that the patient has touched, anything that we have touched in the room after the patient has been, including door handles, etc., etc. And then obviously the PPE that we have been wearing obviously is double wrapped, etc., etc. So it's actually not, I'm sure that's different from the hospital setting, but in our case, that's the only practical way that we can have done that.
And do you get undressed in the hot room, or do you go out? So you take all your PPE off there, okay?
There, absolutely, into a bag, and then we had a room next to the hot room where we could dispose of that and our mask and everything else, yes.
Okay.
Yes, I mean, practical little things, home visiting packs. So one of our nurses sets up an ice pack for you. So you've got your foot covers, you've got your mask, apron, and bags, and you can sort of, you feel a bit of a plonker, but you get dressed up on the patient's porch in order to go into their house, and then you take it all off afterwards. So anyway, that's all kind of practical stuff. And then in the surgery, yes, lots of stickers everywhere and signs everywhere so that the patients are signposted on our one-way system.
Good. Yeah, care and nursing homes, thought we wanted to mention that. It's a big political issue in the UK at the moment. Care homes, were they forgotten? I look after a 75-bedded care home. They went into lockdown earlier than the government suggested, so I think that'll be a big issue, possibly for you guys as well. Lots of remote virtual ward rounds, so getting that set up early is probably a good option for people who look after that. We did have a lot of cases, but in reality, the great majority were asymptomatic, and I think that's where I first met a lot of asymptomatic COVIDs, because people were going in and out of hospital eventually, although the testing was very slow in the UK, certainly in my area. You know, we were getting patients back with COVID who had no symptoms whatsoever before, after, but of course a lot of those patients would have been spreading it within nursing homes. Okay. So we also run a community hospital ward as a practice, just as a little bit of an aside, really. So that became a COVID ward, and so we had to put a lot more work into that. Learn actually, it's two of our doctors looking after direct COVID patients. So there may well be a spin-off and a spill out from primary care into secondary care in that sort of area.
And then just a really minor thing, probably, and I don't know if it's going to happen to you, but early on in COVID,
it did happen.
Oh, did it?
Absolutely, yeah. People, in addition to hoarding toilet paper, were hoarding their prescriptions. Yes.
Yeah, so that was a real problem for the pharmacists actually, and for us.
And certainly in remote and rural Australia, it was really dreadful because there was a whole lot of stuff not available. Thank you, Raz. We might move on to you and then have a look now at the sort of secondary care hospital perspective.
Of course. Hello, everyone. Just a quick run through about our experience from a critical care perspective. Can I have the next slide?
Have the next slide? Yeah, thanks.
So essentially, I'll touch on this, but slightly in a different order. Disease presentation in the main, I mean, you probably have read so much about the main symptoms, but in the majority, if not all of the ones who needed critical care or higher levels of support, the cardinal symptoms that were pretty much universal in them was a very high temperature, I know usually above 39 degrees, a hacking dry cough, apparently, anecdotally, mainly in the evening, and no one knows exactly why that is, if that's true, and associated with that is shortness of breath. Not always very evident, some silent hypoxia, others might talk about later, like Matthew, but thankfully we didn't see that as frequently. Typically they present between 4 to 10 days from the onset of their symptoms. We saw them around days 6 to 7 in ICU in the main of majority of the patients that we admitted. At Addenbrookes, we set up a system where we had 3 separate rapid access and triage and treatment rooms where there were self-contained units within the ED itself. You went in as a team with your equipment and you did everything that you needed, and you had all the equipment so that they were either disposable or kept clean. And there was all separate wards to which people who were critically ill were admitted. And because we have our electronic medical record system and a very effective and efficient and functioning rapid response team, we were able to keep a remote eye on these patients and, if necessary, intervene, accordingly and usually early. Typically, these patients were diabetics, were obese, hypertensive with risk of previous history of cardiovascular disease, and quite frequently with chronic kidney disease as well. And the typical, demographic that we were picking up who had severe COVID. Through the literature, we've seen, and this might change as the testing becomes more widespread, about 20% of tested positive cases need hospital care, out of which 25%, i.e. 5% of total, will need some form of critical care support, whether it's an HDU or a intensive care support itself. So if you turn that into absolute numbers, you're essentially going to deal with quite a big number as an outbreak if you do get a proper outbreak in your hands to deal with. With regards to the clinical challenges, obviously, there are many because people, we were learning on the job, as it were. This was emerging disease. It was novel. There was a lot written from the literature that was, seen from China and Italy. But there were very many different perplexing points about this disease, particularly because the fact that people were catching this disease at different points in their illness, and a lot of things were being published. And perhaps the issue about research governance will come into discussion later on, and publication, and how we were rapidly learning on the job. One of the things that emerged through this whole process is that there are subtypes within these patients who phenotypically have different manifestations of COVID-19. And that was a big debate, especially with regards to the level of respiratory failure and lung injury that these patients seem to have. But it seems to be, and in the literature they mentioned there's two particular phenotypes, the L type and the H type, as it were. And for those who are interested, the L type was the low elastance, high compliance type, and the H type was the high elastance, low compliance type, which, in many ways wasn't in the typical nature of ARDS, wasn't always fitting. However, through the course of the illness, what you realize is that it is a process, the pneumonitic process is pretty much a slow burn disease. And this is a cardinal feature of this disease in critical care. They present very, very ill to critical care, but they respond in the initial stages very, very well. So you might intubate someone who's on 80% oxygen, who is struggling to breathe, who is going rapidly in front of you, deteriorating into respiratory failure. But as soon as you recruit them and then get them onto a bit of PEEP and onto a ventilator, the oxygen requirements come down to 40%, they're very compliant lungs, and then you look like a fool because the fact that you've intubated someone who looked like he was going to die, and why is he still on a ventilator? But through the next 24 hours, the 48, 72, they gradually get worse. And with that, they convert their phenotypical compliant lungs to a stiff, more typical ARDS type lungs. And it's just the course of the disease. And it's partly affected by the fact that if they have underlying secondary bacterial pneumonia they come with, or any other underlying structural lung disease on top. Typically in our patients, they had renal failure as well on top, and frequently they required multiple inopressor support in addition to everything else. The disease itself, some people have akined it to secondary hemophagocytic lymphohistiocytosis, which is a mouthful, HLH, because of the inflammatory syndrome that you get with it. And a lot of things are underway to see if dampening of this immune system may be useful, and hence perhaps the impact we've seen from dexamethasone in the recovery and REMAP-CAP trial of trying to attenuate the immune-related progression.
Is this the cytokine storm? Is that what you're talking about here, more or less?
So the cytokine storm is a much more profound manifestation of this. This is what we call multi-inflammatory, multi-system inflammatory syndrome, of which we've had one case of, which is frighteningly difficult to handle. And it was in a very young 17-year-old. Except for the others, everyone else we've had was a progressive hyperimmune response, but nothing in the level of cytokine storm as such that we saw, especially in that child.
What we're all very interested to hear from you is, as a clinician, I'm here, you were faced with something that was novel. As you say, we were being flooded with information from every direction at that point. And if you were anything, I'm sure you're the same as us, the first thing I do in the morning is check what had happened overnight. And, you know, how did you manage to integrate that into the care that you were delivering to your patients? Because obviously you're trying to do the best thing for them that is known at that time.
So we all went into CPD overdrive, I think, you know, pretty much so. And there's a lot of information gathering and discussions going on. I think, you know, it was mentioned that WhatsApp groups are really useful. It has been immensely useful in trying to disseminate knowledge, but also trying to curtail truth or fact from fiction. A lot of things were being put out there, and not necessarily by people who didn't have knowledge, but also from leading journals with very little scrutiny about what they were publishing, and subsequently, as you know, is retracted. Some more, you know, more headline than others. So we were trying to see if this was a completely different disease from what we've seen before, or a different, you know, compartmentalized manifestations of disease, you know, syndromes that we see in critical care. And with time, what we've realized is that, you know, COVID, whilst it has many features, it does, meet many of the fundamental ways in which we manage critical illness in ICU. So sorry to disappoint, but this is not necessarily a brand new disease that is going to be so out of this world that we haven't been able to manage in the past. But there are certain aspects to this disease that needs to be individualized depending on the cause of the illness. And that's where this differs from many of the others, because this seems to have a variable cause, and therefore you need to be more adaptive in the way that you deal with this disease in critical care. And hence,
I'm not at all disappointed, Raz. I'm deeply reassured that there was some familiarity to what you were seeing.
Yeah, and it was difficult to keep the CPD going because there was a lot of stuff coming our way. I think it was with interaction with people. We have a fantastic group of clinicians as well as support staff, trainees who are very interested and, you know, present things even during handover and meetings. So a lot of things get discussed in dissemination of information, as well as robust debate about what we should be doing. One thing I would say on that front is that we did not use drugs or treatment modalities outside of trials. You know, we had recovery trial, we had remap cap, and obviously with all of the attention that some of the world leaders were giving to hydroxychloroquine and other treatment modalities, there was a lot of pressure coming from families who, in fact, some of them were offering to pay for the drug so that we would be, you know, willing to give it. You know, and you know, it's not an expensive drug, but within the confines of it, and we stuck to our guns with regards to keeping our treatment modalities evidence-based and within a trial as much as we could. Only time I would say we went off-label was with that 17-year-old who had multisystem inflammatory syndrome or cytokine storm, as you said.
And that's such an interesting point, Raz, isn't it? I mean, ethically, did you feel, was that a hard path to negotiate, given how much coverage was being given to hydroxychloroquine and a couple of other things?
It was incredibly difficult because it was on top of everything else that we needed to do. And I'm sure Jane will talk about the communication issues and relatives and, you know, the difficulties of them not being by the bedside, and they want to do as much as they possibly could and can do for their, you know, loved ones who they could not see except through some electronic modality of some sort. And on top of that, they were hindered by what they thought, what, you know, the rest of the world thought was a very effective disease as far as, you know, the media was concerned. And there we were trying to, you know, fight this battle on so many fronts, you know, to try to do the right thing for their loved ones. And it was incredibly difficult. It was draining as well because it was after being in PPE, doing a clinical ward round and a shift and procedures, and then you have to talk to the relatives and then have this debate and trying to, you know, keep them on board whilst doing the right thing for their relatives. So it wasn't always the easiest thing to do. Mm-hmm. Pretty quickly to catch up on the other stuff, we'll talk more about the capacity and other things, but, you know, we early on in the hospital, restructuring to try to cope with the capacity and surgery required. There was despecialization that took place between the non-frontline specialties for COVID. They were assigned ward duties. They were taken away from their primary specialty so that they can manage other things, so that trainees can be released to support critical care, support respiratory medicine, ID, and so on. And this was an immensely useful thing, because what you needed was the manpower, especially the time that takes to look after these patients is absolutely immense. I wouldn't take much time because I've already taken. I just go
no, Raz, but that's right. We'll come back to you. But maybe I could just ask Matt, because we were talking about this a wee bit earlier, weren't we, from a trainee point of view, and you were saying that psychiatrists and orthopods and also everyone was sort of redeployed to be frontline critical care physicians. Is that about right?
Well, it's been varied, and not everyone has been so drastically redeployed, but there has been some really big shifts for a lot of trainees. The anaesthetic trainees have almost universally, because of the cancellation of elective theatre lists and therefore the cancellation of routine operations, because of the aerosol generating proclivity of, they've been moved to intensive care, and so there's been a lot of loss of training opportunities there. But we have been working shoulder to shoulder with orthopedic specialists and general surgeons who've been taken out of theatres because the elective work is just not there, and they've been drafted into A&E and have been pushed towards the abdominal pains and the knee pains and things like that. And we were joking earlier, but we have tried to keep them away from the ECGs as best as we possibly can, and tried to keep the psychiatrists away from the cannulas as best as we can. But we've had a lot of people redeployed, and it's impacted training in a big way for a lot of those people.
Matt, as a trainee in emergency care, has it meant that your scope of practice has really narrowed over the last few months?
In a manner of speaking, yes. One of the things that we mentioned earlier is that paradoxically in A&E we did see fewer footfall or lesser footfall in the emergency department, because a lot of people were frankly afraid of coming into hospital, because they just weren't aware of how we were doing things. In terms of stratifying possible COVID patients into one area and non-COVID patients or not suspected COVID patients into another area. And so people were petrified of coming into hospital. So we've had to contend with that, and so the numbers that we've seen have been fewer, and therefore the diversity of patients that we've seen has been slightly less, and we've, unfortunately, as a consequence of that, we've seen many more delayed presentations of things, things that otherwise we wouldn't usually see, which is what was touched on earlier. It's not all been breathlessness. We have seen a variety of presentations, and we've actually seen a variety of presentations related to COVID-19. We've seen patients coming in with slightly unusual symptoms, and we have started to see an emergence of some of the post-infectious syndromes. My other half works in one of the regional neurology centres, where she tells me we've seen 2 patients with post-infectious Guillain-Barré syndrome, which has been attributed to COVID-19. And we've seen post-infectious brachial plexopathies, which have been attributed to COVID-19. So we're starting to see a few emergent unusual syndromes which don't fit simply the breathlessness and dry cough. So it's been a mixture of different things that we've started to see.
Thank you. Raz, we'll go back to you.
I'll finish off very quickly by just telling you about the numbers we had actually. So we had 96 patients in critical care, which is just about 1% of national ICU admissions across the country. So it took a fair whack of patients into a single centre in the UK. And out of that, in the 10 weeks or so, we went up from 32 beds to, 43 beds to 82 ICU beds to try to make capacity for these patients, and plans in place to go up to 120 beds with support from peripheral units if required. So that was a sort of, the rapid nature in which all these changes needed to take place. Went from 24 to 31 consultant intensivists, from 9 resident during the daytime and 4 resident during nighttime. to having trainees, extra trainees of 15 who came from anaesthesia, and up to about another 450 paramedical staff that Jane would talk about as well. As with regards to our numbers, we had a very satisfying outcome for our patients from a relative perspective. Out of the 96 that we admitted, we ventilated about 83% versus a national average of about 73% or so, and we gave renal replacement for about 36% of these patients, as opposed to 26% nationally. So pretty sick cohort, but the overall mortality was about 34% comparatively to 42% nationally. So the unit overall has done incredibly well. I'll just finish off with one single slide about, next slide please, if you don't mind. This is just a graphical representation taken up from our electronic medical record. The x-axis is days, and each column represents each day, and then the y-axis is saturation for a patient who was ventilated, or it looks of it, on day 2 there, a rapid increase in their oxygen requirement. So you can see the orange, sort of light brown dots, which is the FiO2 requirements, went up to 100% pretty quickly in this chap, and did not respond to, by this time, being relaxed on inverse ratio ventilation, epoprostenol nebulizers, and fluid balance. And they are pretty much most of the ones that we had to then turn prone. And it's letter P, prone, for this gentleman. Has done on 9 separate occasions, was done on multiple inotropes, vasopressors, and quite frequently, most of the ones we turned prone were whilst they were still running on their hemodiafiltration circuits. And this, if you multiply by a X number of patients across the shop floor, and we have to keep proning them every 16 hours and then turn them supine again, and then leave them on their back for 6 to 8 hours and then turn them prone again, is an immense workload for these patients. And some of the data that now we are gathering from our patients and outcomes seems that part of this disease is that the natural progression, as it is a slow burn disease to get worse, does take a lot of time for them to get better. But then when they start to get better, they get better reasonably quickly. But that inflection point seems to be about 28, 29 days in critical care. So if you're trying to plan about capacity, resource, and looking after these patients with this level of intensity, you're going to need help, support, care, some degree of pastoral support for the patient and the staff, as well as being set up for the long haul to try to get them through to that 28, 29 days where the improvement in their survival becomes quite significant. The challenge is getting them to that point, and that all that time there are going to be so many problems down the road of ventilation, septic shock, secondary bacterial pneumonia, renal failure, pressure sore issues, communication issues, families, and we ended up doing tracheostomies with 46% of our patients who then have issues with regards to weaning, ICU delirium, sedation issues, and waking and rehab, all of which I'm sure we'll touch on when you come to our discussion.
Yeah, so we come to, thank you, Raz. And so Jane, I think this is a really good moment to bring you in, because I'm feeling slightly overwhelmed by all those, the idea of all those numbers, as well as 1 and 2 patients needing trachees. So, I mean, this is a huge, huge nursing task, isn't it?
Yeah, it was. So next slide, please. Yeah, so that was, as we were hearing everything that was going on through the rest of the world, we were starting to try and plan what were we going to do. I was being told we needed to double the critical care beds within the hospital and then double them again, and being told, so what do you need? Which was just massive. So as well as wandering around the hospital, working out where I could convert wards to critical care areas and the practicalities of that, we were trying to train staff at the same time. As the hospital was shutting down all its routine things, I sort of was offered lots and lots of qualified staff, but that had never been near a critical care unit and had any critical care training. So what we did very quickly is set up a 2-day program to train qualified registered nurses into the basics of critical care. And we trained over about a 6-week period, 450 nurses to come and join us. The practicalities of then giving them rosters and organising them and communicating with them was massive, as well as the fact that we were teaching them something and then a day or two later we were being told, actually, we need to do that slightly differently, which was very, very hard. The basics of all of us learning safe ways of putting our protective equipment on, and then especially the safe ways of being able to take it off. We obviously needed to make sure everybody was fully trained. We went into this thinking we had everybody mask fit tested. It's something we do, as I'm sure you do, for flu patients every year. But what we hadn't anticipated, that our disposable mask stock ran out quite quickly. So everything that people were tested on, all of a sudden we were getting national stock that we hadn't tested anybody on. And so I had 1,000 staff that needed to go through some sort of testing procedure before they were safe to be able to go into these environments. So that sort of anticipation, I didn't consider anything like that at all, as well as the anxiety that people were having if they were failing those tests and the masks weren't fitting properly. At the same time, we were trying to stock up with ventilators as far as the basics we needed, syringe drivers, monitors to be able to look after all of these patients. And they weren't all the equipment that our staff were safely trained on. So we had to set up very quickly top tips, trying to make it as safe as we possibly could to be using this kit that none of us were particularly familiar with. The disposables we were using, we started to find our procurement chains were falling down. The kit that we were used to using was no longer available. So on a daily basis, I was being shown various things. Would you be happy to use this? Would you not? Whereas in a normal life, we would have spent weeks all talking about it, looking at these things. And it was just a case of I was making that decision on the spot, saying, yep, that's fine if that's all you've got. Drugs, as you've already touched on, even in the community, we started to have issues as far as knowing there were going to be some shortages, often of the key sedation that we use in critical care. The nurses are obviously very trained in this sort of thing, but all of a sudden they were very diluted at the bed space. It might be one critical care nurse supervising up to 4 patients instead of 1, and those staff that had come to help us. And at the same time, we were using unfamiliar kit, and we were using drugs in different ways or slightly different drugs. So everybody was feeling very, very uncomfortable and anxious about that.
Extremely stressful, Jane. I'm not feeling happy hearing all of that, because this has all been happening over a couple of weeks, wouldn't it? Every day, something different.
Yeah. So very, very anxious. Staff were very anxious. And that was something we sort of tried to anticipate at the very beginning. So we have a team of psychologists and psychological well-beings that work in critical care. Normally they have a 3-pronged approach as far as they're there for our patients and for our relatives and for our staff. And we decided straight away that we needed to just redirect them for staff at that point, so that there was access for people to come and speak to people, talk about their anxieties, and go through that side of things. One of the hardest things we had to do quite early on, once we started getting COVID patients in critical care and in the hospitals, was stop visiting. And that, I think that was probably the hardest thing I had to do, go around and speak to relatives and say, you know, we're going to have to ask you to leave today and you can't come back, when their relatives were so poorly and so ill. And the response was incredible. People just went and said, thank you very much, you're so brave, and that was amazing. What we did as far as communication with them is we set up teams from the staff that were working at home so that we could do regular calls, and as we got slightly more tech savvy, we set up Skype and those sort of things, which we haven't done before in critical care. We have this difficulty as far as our patients don't have capacity. So if we're using Skype, they haven't necessarily agreed to do it, but we decided in sort of difficult times like this that, you know, their loved ones needed to be able to see them. So that was sort of a completely different way of working for us.
Earlier we were laughing at this lovely sort of Vogue cover picture of you there, and you were talking about the challenges of working in PPE on long shifts. And I asked this question, which I've been asking for months, which is how do you go through a whole shift without having a tea or drink of water or having a wee? I mean, it would be absolutely exhausting.
Yeah, very, very hard. So we aimed from the beginning, from a practical point of view, that we would relieve everybody routinely between 3 and 5 hours during what is generally a 12-hour shift within critical care. Obviously, some people manage that well, and other people needed breaks a lot more frequently. When you put these very tight fitting masks on, it is a lot of mind over matter. You have to absolutely focus on something else. It is very hot, it's very claustrophobic. So we did have staff having panic attacks and needing for them to get out of those spaces quickly. And obviously just trying to look after each other was really, really important. We stopped at the beginning. We would normally get all the team together, which is probably about 30 to 40 people, to do a very quick safety briefing as to what's happening. When we were trying to social distance from each other and not have too many people in a close room, that made that very difficult. As well as what we found, putting PPE on is quite time consuming, and we were really trying to make sure people took their time and put it on properly. But equally, we didn't want the shift that they were going to be taking over to be leaving late, because everybody was really, really tired. So one of the things we stopped at the beginning was handover, that people turned up on shift straight away, could see on a board where they were going to be working, and went straight into that area to get a sort of bed space handover. We've really found that there are problems with that. We can't give key messages, key changes. And so actually what we're now starting to do is slowly come back and restart those handovers again. Some people are very uncomfortable with that because we haven't got big spaces to do that in, and we've very much left it to an individual. If people are comfortable, they come into the handovers, and if they're not, they can just go straight into the workplace. So I think...
Sorry, I just noticed that there's a couple of questions starting to come in, and I'm really conscious of time as well, and want to give Matthew a chance to speak a little bit as well. But I thought I'd ask that first question for Sally and Mark. Just saying that, you know, with Mark being somebody who might be more at risk, but Sally seeing people face to face, you know, the potential of you bringing something home, how do you reconcile that? And the question asker is saying they're in a similar position where their partner's at risk. So yeah, just wondering your comments on that.
Yeah, so that was a huge anxiety at the start. Basically, when I go to the hot site, I change there into scrubs and PPE, and after working at the hot site, I shower and change back into home clothes again when I get home. So that is hopefully reducing the risk as much as I can. At work, we change into scrubs and PPE at work, and then we change out of our scrubs into work clothes in the evening. And so again, there's only so much we can do, and we decided very early on that I wanted to continue seeing patients, and it was the sort of, we realised it was never going to be 100%, particularly the fact that obviously there are so many asymptomatic COVID positive patients anyway, but that's pretty much how we run it. Yeah,
if I can add in there, I mean, my frustration is very much not seeing patients, so it's more that way around. I know Sally was very worried about me. Just an aside, we were very reassured. Our son's also a junior doc up in Sheffield, and his colleague has been working on the COVID ward for the last, well, two and 3 months now. And there seems to be very little pickup of COVID from the staff, even though they were continually working the hot sites. Appreciate the PPE is different, but I think that we felt quite reassured by that. And we've had, as far as I'm aware, not one staff member contracting COVID at any stage so far. Now, part of that may be because there's not too much testing.
We haven't been tested.
But very little symptoms. So far, so good. So I think quite a lot of reassurance as long as one is careful.
Yeah. Thanks. I've got friends that that use their garage where they sort of strip off altogether, run to the shower, and then get on with the evening when they come home. Just a quick question for you, Raz, as well. You mentioned that your own hospital had essentially doubled the capacity for ICU beds. Is that a pattern that you see nationally, or in terms of, or has it been more than that or less, or is that about the same?
I think most institutions increase their capacity quite significantly. There are some, smaller institutions starting off with 8 beds. They may have gone up to 32, so it's essentially quadruple. Right. But they were really struggling, and they were the main units. So it started off with a small sort of footprint in their critical care area that needed to perform inter-hospital transfers. So almost every hospital that I know of increased their critical care capacity, but up to varying degrees. As a percentage, it would have been very significant for the smaller units. The tertiary centers increased them, significantly. We didn't need to move anyone out of our center for non-clinical reasons. We did transfer 6 patients for ECMO to our local cardiothoracic unit, but other than that, we didn't need to move anyone out. So that has been a universal thing. And about the Nightingale hospitals that became superfluous.
That's
but
right.
also they weren't equipped to deal with the type of sickness that we were dealing with. They wouldn't have been able to look after patients with multiple organ failure, essentially old anesthetic machines by the bedside and not much space. So most units did increase their capacity significantly.
Just before we go to Matt, sorry Jane, we might have to skip through your slide, but can you give us a sense of how many staff per shift you would need? Oh, no, let me restart this. That patient that Raz showed us, the number of times you were turning him from prone to supine and so on, how many staff have to be involved in that sort of movement of patients?
Is that for me?
About 6. Sorry. Oh, sorry, Raz.
No, sorry, Jane, that's me.
About 6 staff would be needed for that. So one of the things we did do was also train some of the theatre support workers. We did a little half-day session for sort of how you reposition unconscious patients and also how you prone unconscious patients. So we had a little team of up to 5 people when we could, going around and sort of turning patients either supine or proned, sort of flipping them over as we went round, and doing some personal care and then carrying on. So it was quite ruthlessly organised.
Yeah, thank you. Tanil, could we skip through just to Matt's slide, the next slide, that's the one, and skip again so we see the little chart, that's it. Matt, do you want to talk us through a little bit of this?
Yeah. So we'll get through this slide pretty quickly. And apologies, there's lots of numbers on here, so it's not the prettiest of slides. My name's Matt. I'm one of the acute common care STEM docs. So what that means is I'm an SHO level trainee in going into one of the 4 specialities you can see on here. From my time in Australia, it'd be roughly equivalent to a sort of PHO or junior reg position. I've been working in the 8-bed COVID pod, which was the allocated area within our emergency department in the district general hospital in which I work, receiving the COVID patients, or the possibly COVID patients, the suspected COVID patients. When I was asked to sort of talk about my experiences, I thought the best way to do this was just to show you 3 ABGs from 3 patients who presented to our department. And these were three of the quite unwell patients, and the majority of the patients we were seeing were actually very well, albeit syndromic of COVID-19, but they were very well, and most of them were able to be turned around and told to self-isolate at home. But these were 3 patients who were profoundly unwell, 2 of whom walked into the department from their own private transports, and they were very much symptomatic, but they were well enough to make their own way into the department. And the take home here is they were all in profound type 1 respiratory failure. This is the presenting blood gases that were taken after they were stabilized on oxygen with a non-rebreather mask at 80 to 100% inspired FiO2. And you can see their PF ratios were indicative of really just massive ARDS. And these were the patients that were very, very early on escalated to intensive care. And all of these patients were intubated within 10 hours. Interestingly, all of these patients actually presented exactly on 10 days into their illness and had a prodrome of 10 days of fever and dry cough. Unfortunately, 2 of these patients sadly died. One of them has been discharged from hospital and is ongoing post-intensive care rehab. So if we go on to the next slide. So this is just, I'll leave you with this and you can just sort of have a flick through, or it might generate some questions. But essentially the challenges that we face, particularly as a trainee, the biggest ones that we faced are exactly the same as everyone else, which has been the personal challenges associated with lockdown and the COVID-19 situation, but also the actual experience of what we're doing in hospital to these patients and what's been happening on the front line in the emergency department. But there has been some individual changes to training. My annual review of competency progression has been suspended this year. I've had to change the way I evidence what I've been doing this year. And unfortunately, I've not been able to go to certain courses or fulfill certain course requirements, which has been taken into consideration by my training body. But obviously a lot of my colleagues have been redeployed to other areas, which is what we were talking about earlier. And we've seen a lot of my surgical colleagues have their training amended in certain ways with cancelled theatre time and decreased exposure to procedures. One of the things that's been a big challenge on the front line has been the issue of DNA CPRs, and particularly with care homes. And one of the things that we've seen is there's been very extensive empirical discussions with some of the more frail and elderly population from community primary care and also from secondary care, about having conversations about putting in DNA CPRs, which I think in Australia are called ARPs from my recollection of my time in Brisbane, advanced resuscitation plans. But essentially we've had to have more widespread conversations about that, and it's generated a lot of political discussion about what's been going on in care homes. And what we've actually seen in the emergency department has been a lot of elderly patients with DNA CPRs and family members who we've been having conversations with. And they've said, oh, well, now that COVID's over, I don't think we want a DNA CPR anymore and we can tear that up. And there's been a lot of misunderstanding about the nature of the DNA CPR and the nature of the advanced directive. And a lot of people who've been wanting to change their advanced directives based on the fact that we thought the hospitals were going to be full to the brim, and a lot of these elderly patients wanted to give up their hospital beds for the younger persons. And it's been a challenge to overcome that, more so than it is, because it's a difficult conversation to have at the best of times, but it's been a real challenge to take into consideration the pandemic effect on that conversation. Yeah, so I suppose.
Thanks, Matt. I think sadly we're nearly out of time, unbelievably. So if we could maybe go to the next slide. We were hoping to have several minutes to talk about this, but we're not going to. So Raz, just briefly over to you to talk about that post-ICU. If you could just summarize for us in 30 seconds. And you'll have to come off mute if you want to do that.
Essentially, the point I was making is that the duration that most of these patients need to recover from their critical illness is very long. And you need to plan for that, and both with regards to structure as well as clinical management and relatives' expectations and so on. But part of that whole package is going to be that quite frequently they do end up developing quite complex problems associated with physical as well as psychological issues and ICU delirium, but also compression plexopathies as being in position or otherwise, and needing a tracheostomy and trying to reset their daylight and nighttime patterns, and then getting back to life in a slow manner that can be quite difficult for themselves as well as their families. And then they're not necessarily after that returning to a normal set of life, they're going back to a new normal in the setting of COVID, which adds a further set of stresses and problems to themselves as to their families. We do have some specialist nurses who are who specialize in looking after these aspects, but they're also very, very stretched because of numbers as well as the time it takes to look after them. So it's a big challenge going forward.
Big challenge, yes. Thank you, Raz. And Jane, just over to you briefly. You spoke a little bit about staff who had to shield at home and then weren't able to come into work, and now managing some of that anxiety and that difference.
Yes, yeah. So I think just as we've already talked about with the WhatsApp groups and more Zoom meetings, we've been trying to incorporate staff so that they feel like they've been in touch. But I think they do feel very guilty that they haven't been able to work for their own health issues or the fact that they've been shielding for family members. We've been trying to do everything we can to sort of offset that. But we now have staff from the 1st of August are going to start coming back into the workplace. And we're starting to see obviously huge anxieties as to how they manage that and how they can do that. The other thing I will touch on from what Raz was saying, what we're also finding is our ICU patients normally have the relatives telling them the stories about how poorly they were and what's happened, but because they were not physically in the hospital seeing that, they can't explain to them how poorly they were and why this is taking such a long time. And the same for the relatives to understand what they've been through. And I think that's a new phenomenon that we're going to see, and you'll see in general practice, that the relatives haven't experienced it either. So they can't share quite the same and reassure their loved ones.
Thank you. Last 30 seconds to Sally and Mark, I think, and then we'll put the QR number up.
So is this the moving forward, really?
I think so, yes. Yes.
Yeah, I think that, general practice has changed along the lines we're talking about. Our patients are changing in a big way as well. Just a quick one, we're seeing a lot of patients post-COVID or presumed COVID who are tired for months, and we keep coming back, why aren't I better? So I think this is going to be a long running issue. Very much as far as our staff and clinicians on the secondary care is keeping everybody on board, I think is the biggest issue here. Changes will happen. We have some influence on that, but a lot of it is external influence. And we need to keep in touch with our secondary care colleagues because, we've actually been pulled apart somewhat because of the non-contacts. And I think we all need to keep in this together for a more positive long-term outlook. Good luck.
Thank you so much. We've got a couple of questions which we will, there's people are saying thank you. We'll send that to you. Thank you again so much, Matt, Jane, Sally, Mark, and Raz. Thank you for giving up your time. It's been fantastic to have you with us. And we wish you a lovely day. Good night, everybody.
Thank you.
Fantastic reflections. Thank you.